And now we move to the second part of this session, where we're going to have the interaction with the Multidisciplinary Tumor Board. And I asked to come to the podium Axel Grothe, Charlene Gil, Michelle, Thomas Gruenberg, just to discuss the cases that Eric Van Kutsen will be presenting.
Okay. We have taken a couple of real cases just to discuss. There's no right and wrong answer, but just to discuss some of the important topics. Yes, in this regard. And the first case, the first patient was a patient who presented actually 2 weeks ago, and for the first time, or 10 days ago in our department. 27-year-old young lady, no medical history, no familial history for cancer. She was a young mother of 2 young children, and she went to her gynecologist because she had abdominal pain and a feeling of sensation of something that was pushing in the lower abdomen since a couple of weeks. No other symptoms, no change in stool patterns, no weight loss, ECOG 0, of course. Blood test was done, no relevant abnormalities, no normal organ function. Her gynecologist still did an ultrasonography and found an ovarian mass, large ovarian mass, and I will illustrate that immediately. In this setting, very suspect of a tumor, thinking this was a primary ovarian cancer. He did already some tumor marker analysis also on that. At that moment, the CEA was slightly elevated. The CA 125, which was in our setting borderline elevated, but not what we would expect with primary ovarian cancer. He did a CT scan, abdomen and thorax, and this is from, as you can see, June the 14th. You can see the very big mass in the ovaria. You can see different sequential images in this setting. I don't show you the whole scan, but you should believe me that there were no abnormalities in the liver. On the CT scan, there were no abnormalities in the lungs, and there was no primary tumor found in this setting. The gynecologist at that moment was in doubt, is this a primary ovarian cancer? Could not exclude that. Or is it something else in this situation? And so he did some further examinations, and he called us, and this is all 2 weeks ago, as you can see, and then we did a further next investigation. But maybe let's pause here with the panel diagnostic exploration further. Somebody wants, that's what we do have.
I can take the lead just to start. So when we see masses like this, especially in the gynecological tumor ward, actually they call the medical oncologist because also the fact that the tumor markers for ovarian cancer are not highly elevated in this particular case, there is always a possibility to discuss a potential Krukenberg syndrome. And for this particular case, what we do is gastroscopy, a colonoscopy, and obviously a mammography in order to rule out the most frequent origins for Krukenberg disease.
Yeah, that's what we do as well.
We did first not do the endoscopies, but we have access to fast total body MRI in this setting, and that's what we did because there was a tumor. With the gynecologist, Injas Vergoten was not sure that this was an ovarian tumor, and an MRI was done, total body MRI. And you can see on the left image, I don't know whether I have a pointer here, you can see on the left image with the arrow diffusion weighted, on the diffusion weighted image is also a tumor mass that was suspected to be in the descending part on the colon. You can see that in the middle scan also with the arrows in this setting. And also on the right images, there was some peritoneal thickening, and you can the lower arrows, and also you can see on the upper arrows, on the upper right image, if I have to, yeah, okay, I've got it here. You can see here also some diffusion-weighted small deposits. In our experience with this total body MRI scans, this is quite accurate to predict a correct diagnosis. So with these images, with here a lesion that if reconstruction was done, suspicion of a primary tumor in the colon, a colonoscopy was done. This is all in 1 week. June 14th was the first scan, the MRI, and then the colonoscopy. And you can see a primary tumor in the descending part of the colon without clear occlusion, without obstruction. Biopsies were taken at that moment, and this is from last week. Biopsies were taken which showed typical image, and I just take you show you a couple of the images. A typical image of an intestinal adenocarcinoma, as you can see, immunohistochemistry confirmed also with cytokeratin staining, and the tumor on immunohistochemistry was microsatellite stable. Last week an NGS panel was then started in this patient. So we're there with the patient, straightforward, the real presentation of last week. Young lady, primary colon cancer with a big mass, as you've seen on the different images, in the ovaria, Douglas metastasis, and with the suspicion of thickening, as you saw on the previous slide, thickening also of the peritoneum here, and a couple of small omental metastases with this tumor that could be passed with a normal colonoscopy in a lady without symptoms, change in stool patterns. So that's the situation, and that's the case like we have it a couple of days ago.
I would go for surgery. Even if I am not a surgeon, I would go for surgery.
The question is, that's the question that we discussed on our tumor board also. First question is, how do we start, how do we approach in this setting? Do we go for surgery with the fact that, that there is a suspicion of metastasis in the peritoneum, the thickening, and a couple of omental deposits, as I've shown you here also. And I have to say, this type of MRI scans, yeah, I know it's new, and I know some people are skeptical, but we have a large series of many patients with quite good accuracy in this.
Yes, we are evaluating peritoneal carcinomatosis with this kind of tool before to do a peritoneal surgery. But I would say there was a little bit ascites on the CT scan. When you presented the third CT scan on the right, there was a little bit ascites on the... and we know that when there are peritoneal, when there are ovarian metastases, yes, on the right part, you can see a little bit ascites.
And here,
yeah, absolutely.
That's correct.
And we know that in patients with ovarian metastasis, the risk of peritoneal carcinomatosis is increased. So I will go for surgery not for diagnostic, I would say, but because we know that chemotherapy is not very active on this pseudocystic ovarian metastasis. We have reported that in my team. And probably it will become more and more symptomatic for the patients, and so I would be in favor of surgery first.
Axel.
So I agree, but I also believe the question is, when do you do surgery? Yeah. And do you do chemotherapy first to see, you know, that you see some response or not? I've not used this DCE MRI as a DCI MRI or weighted MRI as a measure to really reliably identify peritoneal metastasis. In our shop, we probably do a laparoscopy to also to really confirm this histologically. But I agree, you know, it's almost certain that there's peritoneal disease. And there's almost certainty that these large cystic ovarian masses do not well respond to chemotherapy. And this is different than ovarian cancer. This is a very interesting biology that Krugenberg tumors do not respond, even if systemically you see response in liver metastasis, peritoneal disease. So at some point these lesions should be resected, even for palliative intent. But with this low peritoneal carcinoma in the carcinomatosis index, this could be a case for cytoreductive surgery without HIPEC, because I don't believe that HIPEC works in colon cancer.
Well, perhaps I think that I would do the same. Perhaps the surgery obviously would be an exploration of the abdominal cavity. I think mapping is important for a second step because the patient has, limited disease showing that there is no liver and lung metastasis. And I fully agree that the response rate in masses in the ovaries are really very low, and usually these patients progress very rapidly, become very symptomatic. Primary tumor is not symptomatic, so perhaps, as mentioned, mapping of the abdominal cavity plus removal of the ovaries. Usually, Krukenberg disease is bilateral by definition in most of the cases, so something to discuss also with the patient because actually she's a 27-year-old female, but that would be our preferred option first, and then start with chemotherapy, and if there is response of the residual disease, perhaps considering a second step, full surgery.
Yeah, I think at our tumor board, there would be the question would be timing for surgery, but I think the recommendation would be to start with chemotherapy first to get a better sense. This is a young woman who's presenting with synchronous bulky disease. I would have expected the primary to be on the right. I was somewhat surprised to see a left-sided primary with this kind of presentation, but nonetheless, I think the goal would be whether she could be the possibility of cytoreductive debulking with or without HIPEC could be accomplished for her. But I think chemotherapy up front would be important, and knowing her NGS, RAS and BRAF status would be important as well.
You still use HIPEC?
Our surgeons still find reasons why they think it might be a good idea.
I never understood, because we know the surgical approach, cytoreductive surgery, works, but they think that chemotherapy works. And I don't believe that as a medical oncologist, I don't believe that sprinkling heated chemotherapy on the surface of peritoneum, I think it's not what we should do.
Yes.
Interestingly, we had exactly the same discussion with exactly a similar young patient in a huge colorectal cancer conference in Shanghai just 2 weeks ago. And it was the same discussion. So the medical oncologist said we have to give some chemotherapy at least at the beginning, and the local surgeon said we operate on that patient, and they operated. They left, so they did complete peritonectomy together with the primary tumor resection, which I would intend to do as well. They left the contralateral ovary because of the young age. Patient recurred within a year in the contralateral ovary. So therefore, I think we, even in the young age, we would have to do ovarectomy in both sides together. I would personally do, also I'm not doing peritonectomy, so I will send the patient to somebody who does this on a daily basis to do peritonectomy. I personally would prefer to do it systemic treatment for 2 months, as we do in most other metastatic patients, just to get an idea of response. Also, she's symptomatic from that pelvic tumor. The other thing I wanted to highlight is this: most patients, most doctors that are dealing with peritonectomy and HIPEC still do HIPEC, apart from the fact that we have negative titer on multiple occasions.
Yeah, we had a similar discussion in our board, so last week, just before I came here, and it's clear that this patient will have to undergo one-day surgery, and the question was, should we start first with a couple of months of chemotherapy and followed then by surgery, and if responding well. in that scenario, debulking and HIPEC if she was responding well and at a low PCI, peritoneal carcinomatosis index, or to start immediate with surgery. We decided to start with the chemotherapy for 2 months, and then in function of the response, do a new MRI, and then probably go for surgery in this setting, and then discuss to see what type of surgery it would be, depending on the response. For sure, take out ovarian mass, the primary tumor, and then see whether debulking is feasible or not. We decided not to go for surgery right now, indeed, because, as was said, she had not a lot and no clinical relevant ascites, but she had a little bit of ascites in this setting. And we said, let's try, she's 27 years old, try to induce a maximum response and see what's happening.
So would you use bevacizumab in this patient?
No, we said the NGS panel was not available yet. We started the last week with FOLFOX, and the second cycle we will add in view of the RAS status, either upgrade to FOLFIRINOX or eventually, depending on the RAS status, FOLFOX plus an anti-EGFR antibody. That's our strategy.
I would say that another argument to go first to surgery is to be sure that the peritoneal carcinomatosis index is not too high, because if it is very high, it means that there is no possibility, no further possibility of a curative surgery, peritoneal curative surgery for hope. I agree with Axel. It has been demonstrated in France, and I am French.
Our radiologist, Michel, to answer your question, did a mapping, and nothing is 100% perfect, but there's quite good correlation with these MRIs.
Okay.
They spend a lot of time, and the PCI was relatively low.
Okay.
So you don't use HIPEC anymore.
Okay. Other?
So despite the fact that bevacizumab is working in ascites patient or peritoneal carcinomatosis, you would not use bevacizumab?
Chances are low, because our plan is to go after 2 months of chemotherapy, do an evaluation, and then to go for surgery in this setting. And it works in
ideally after bevacizumab.
ascites, but that's not always the case in colorectal cancer.
Okay.
Can I make a plug-in for genetic medical genetics consultation? I think we need to have this patient seen by medical genetics too. A 27-year-old patient, even if you have immunohistochemistry, mismatch repair proficient tumor, I think these patients should be analyzed for some germline deficiencies.
But that's already done in the meantime, yeah. Okay. So as I said, no right, no wrong answer, different views in this setting. The second patient is also a young lady, 36-year-old, without a history, without a familial history, who presented with a left-sided primary tumor, sigmoid colon, without symptoms of occlusion, but with extensive liver metastasis in both liver lobes. ECOG performance status was 1, or alkaline phosphatases were a bit elevated, normal bilirubin, but the liver function on itself was good. Further profile was RAS wild type, BRAF wild type, microsatellite stable tumor. Remember, as you can see, this was a couple years ago that this scan that the patient was diagnosed. The patient is a fighter, clearly, in this setting, with synchronous extensive liver metastasis in this setting.
Liver only?
Liver only, yes.
Surgery.
Thomas.
Yeah, we can preserve a bit of liver here. No, we would certainly start with systemic treatment, and we would start with triplet together with an EGFR receptor inhibitor. Also, we have very good data with bevacizumab as well, I have to say.
So what is great is that you can see that surgeons are speaking about chemotherapy.
Yeah, that's what we do most of the time.
Medical oncologists are speaking about surgery. So this is the real multidisciplinary approach of these patients, I would say.
Okay. So she started with chemotherapy some time ago. At that moment with a doublet, FOLFIRI plus cetuximab. After a few months of treatment, as you can see, as you've seen the previous scan, It was a nice response. Liver disease was not clearly visible in the left lobe anymore on scans, and MRI was done also at that moment. And you can still see the liver metastasis on the right lobe. The primary tumor was still present. Remember, this is the image here, as you can see here. Question is what to do now?
Call Thomas.
Thomas, yeah, well,
At least discuss in the multidisciplinary board if there is some possibility of surgery, obviously.
I mean, the problem is I do not have a pointer now, and we do not see the same images, the same level of images, but she has had quite huge metastases just pushing against the left liver vein. In this image, you can do remove the right lobe and thereby clear the tumor in the liver. You said you did an MRI as well. You have excellent liver surgeons in your hospital, so I assume that they have looked at this tumor on the left side. The problem is that patient received 6 months of treatment. What I have to say is we always intend to do our resections after 2 months. Best response is usually after 2 months. They do respond further, but they do not respond as well as after 2 months. Anyway, after 6 months, you have to do some form of liver function testing because the patient will not benefit from a resection if she has liver dysfunction afterwards. I would not combine a liver resection, if intended, with the primary tumor resection because we do not do this together with the primary if the liver resection is major.
With the size of the left lobe, will you do two-step process?
No, that's large enough, the size. But it's important that we measure the function. If the function is in the right range, then the volume of the left liver is enough.
And the fact that the patient had initially metastasis in the left lobe, wouldn't you like to do an intraoperatory endoscopy before going to the...
I mean, you have to do intraoperative ultrasound, but the best imaging prior to such surgery is liver MRI with Primavist. So if you do not see any tumor anymore on that MRI, I have never found anything additionally during surgery apart from some superficial lesions which you cannot see.
Thomas, suppose that the liver function with this liver function test was good, and the fact that we continued, or that she was continued with 6 months of chemotherapy was that she was responding in the beginning, but she had very extensive disease. We discussed that every 2 months after every evaluation at the tumor board. She's a young lady in this setting, but at the different time points, and indeed because of the close attachment to the blood vessels, it was not yet decided to go for surgery. At this time point, it seems that it was feasible to go for surgery. Liver function was okay in this setting. So would be then the approach simultaneous resection of the primary tumor plus hepatectomy?
No, as I said,
one time, 2 times?
I would not recommend doing this together because the likelihood of having a problem with the anastomosis of the primary tumor is very high. It can be done, but there you have to discuss with the patient. That's what I'm usually doing. I'm saying I can remove the primary at the same time, but the likelihood of having a problem is much higher. So it's not in every patient, but the chances are about 50% that they have a problem with their anastomosis.
Suppose that during the operation, because that was a scenario that we discussed also, that there would be still, because at the beginning on the left lobe there were metastases, that during the perioperative ultrasonography there was 1 or 2 small metastases found in the liver lobe. Would you then touch upon that on the liver lobe during the intervention? Do the resection of the primary tumor touch upon the liver lobe, or would you leave it like that and say never cure?
There are multiple options in this setting. One is to clear tumor on the left side, do a minor resection on the left side, then you can remove the primary with this during that surgery as well, and do the right lobe after portal vein embolization, which you can do during that procedure. That is one option. The other option is that you clear tumor in the left lobe, do a split or do a portal vein embolization during that procedure. If you do a split, I would not remove the primary. But the best option is most likely to clear the left liver, remove the primary, and do the right liver 4 weeks later.
The oncologist, any suggestions, any other additional remarks, Charlene?
Just, I guess, a question for the panel. I mean, she clearly responded to the FOLFIRI and cetuximab. In Axel's discussion earlier, he talked about our reticence for triplets in general, and I wonder if anyone in the panel would have considered a triplet, or possibly from the Volfi data, you know, with the response rate of like 87%, considered a triplet plus an EGFR.
Remember, the case was a couple of years ago.
Yes,
before
I understand that.
But the question is for today, yes.
I would go for triplet now. Yes,
Me too.
I agree.
Me too. Triplet, panitumumab, or cetuximab. Yeah.
She's young.
Yeah.
He's a perfect candidate.
Perfectly. And potentially resectable metastasis is interesting too. But a question to Thomas, and what about the reverse? I am not sure that you propose that. Right hepatectomy, radiofrequency ablation of the two small liver metastases, and then performing surgery of the primary 1 month later? Is another possibility?
Other option as well.
Okay.
I just would, because we have the whole GONO group sitting here in front of us, would you also give an EGFR receptor inhibitor nowadays? Yes.
Yeah.
Alfredo is giving an EGFR receptor inhibitor. There we go.
Okay, so the patient had indeed a scenario what you said as one of the options, Thomas, section of the primary tumor. There was a metastasis found in the liver lobe still, and there was a ligation of the portal vein done during the intervention, and a little bit later she underwent a right hepatectomy with, again, a new metastasis that was found in the left lobe at that moment. So that's the strategy.
But
finally...
May I just, because
yes.
What I find interesting is that normally on MRI, because you said you did an MRI as well, you normally see the remaining small lesions. They were not detected at that point.
They were not formally detected. We had a suspicion it was a very small lesion. We had the suspicion that there was something. That's why this scenario was thought through before the intervention, yes. Do we have time, for just a short scenario?
Yes.
Or do we stop?
3 minutes.
Another
5 minutes.
Yeah, it's very short. Just a couple of topics for discussion. Again, another young patient, a female patient, 29, different setting than the previous, which was diagnosed with a rectal adenocarcinoma in the proximal rectum, and with also some synchronous small adenomas. That's not so relevant. She presented with oligometastatic disease. And she had the primary tumor that was involved of the mesorectal fascia, CRM positive, and she had one liver metastasis. I'll show you the images, and two synchronous lung metastases also. So synchronous oligometastatic disease. We did an expert discussion with around 40 experts, faculty and scientific committee a couple days ago, just to discuss some of the strategies, what we should do in this situation. Molecular profiling of the tumor further at that moment, 2017, was RAS wild type, BRAF wild type, microsatellite stable. You can see some of the images. It's, of course, selection of the images. You can see one of the lung metastases. You can see the liver metastasis. There was a very small peripheral lung metastasis in the right lung also that is not shown here. And then you can see the primary tumor in this setting. And just for discussion, the strategy, a little bit like we did with the expert discussion a couple of days ago with voting, but now you have the real case in this situation. What would be the approach, different panel members?
Short course radiotherapy, then 2 months of chemotherapy, then resection of the abdominal part.
So you would start with short course radiotherapy. Would everybody agree with that?
So I would start with chemo and then wedge in short course radiation therapy and then go for metastasectomy. And you know, these metastases, at least as a non-surgeon, I think they're all technically resectable. So you do not need shrinkage as much as you test biology So we would start with chemotherapy. Short course radiation, I think, is a perfect scenario here. But I agree, you know, we don't know what should come first. We have no idea about the right sequence. Chemo, short course radiation, chemo, resection, short course radiation, chemo, resection. I don't know.
I am not sure that there is a best option.
Right.
I think we have to put together radiotherapy, chemotherapy, active chemotherapy, and surgery. And maybe the sequence is not very important.
Right.
Was there any symptom? It was symptomatic? No, not symptomatic.
She had very limited symptoms at that moment.
And I think, you know, the question about, well, it is upfront resectable, testing the biology is important. She has multifocal synchronous metastases. And so we would, in our center, we would favor starting with chemotherapy and then, as you said, figuring out the optimal timing to manage her primary with radiation. And my question to you, Eric, is why are they all young women?
Yeah.
Why are all of these cases young women?
Who knows? Who knows?
It's an epidemic.
Well, because it's an increasing problem. We had a talk a couple of days ago also of young patients. It's by chance female patients, but there is an increasing incidence of young cancer patients, as we all see, and especially in these young patients. The strategy in older patients is also important, but this is even more challenging in young patients.
For the case with ovarian metastasis, there was no other possibility than a young woman.
Yeah.
Okay, so just what we did, we started with chemo, she had a nice response, then we did a short course radiotherapy and went to surgery in 2 steps in this patient.
Which chemotherapy did you use?
At that moment, we gave a doublet, FOLFOX plus an EGFR antibody.
Yeah. Doublet, yeah.
So that's just because it's resectable disease, and we very often discuss what do we give with resectable disease.
But also with the fact that there was invasion in different organs.
Yes.
That's
everybody gives in resectable disease still an antibody. Also, we do not recommend this in the...
We don't do that in resectable liver metastasis only,
absolutely.
but it's
Absolutely.
for multiple
Agree.
organs, that's what we do. Yeah.
Yeah.
Okay, thank you so much for
Thank you very much.
participating
Thank you
and
to all panel.
trying to stick on time.